to structured medication reviews. Hopefully you've all heard the term. A structured medication review goes beyond a review of medication, where you look at a list of medications on a computer screen and say, yep, they all look good, keep going. A structured medication review, again, puts the patient at the centre of their care. And it's time to talk to the patient about how they got to be on all of these medications and whether, in fact, they are taking them, whether they're helping them, whether they're experiencing any of the potential harms from those medications, and what they would like to get out of this consultation. Now, I know a lot of those things can make the healthcare professional in you feel quite uncomfortable. It goes with, what would happen if we allowed a patient to talk for as long as they wanted to? It might be for an hour, but it generally isn't. And actually, most people are quite sensible. And when they come in, they'll say simple to deal with things like, I would like to take fewer tablets. That's what the majority of my patients say. Can you get me off these medications? Well, I will work with you to try and do that. And if patients have an understanding of why we've prescribed each of the medications, they can then make an informed decision on whether they're going to take them and continue to take them. So the people who are eligible for a structured medication review are going to be those who are at highest risk of harm from medications. Anyone living in a care home, residential or nursing, is eligible for a structured medication review because they will tend to be most vulnerable to the harms from medications and more likely to be people living with polypharmacy. Now, the definition of polypharmacy, I think for some people, can be a threshold of 10 medicines. It can be as few as 4. We're looking at problematic polypharmacy. So if they're on any number of medications, basically, that are causing problems, then it's problematic polypharmacy. And we, of course, should focus on those who are on more medicines. Goodness knows, I see people in my clinic on 20 or more medicines with lots of complex comorbidities. But people can have trouble with any number of medicines. We should also, though, be looking at people who are frail, who maybe are housebound, or who are on medicines that are more likely to cause harm. So the DMARDs and the Z drugs and the dependence-forming medicines. None of this is news to you, but these are who we focus on in my practice when we invite them in for a structured medication review. I said earlier that we know that 50% of patients don't take their medicines as prescribed. And it's really interesting to explore whether that's intentional non-adherence or unintentional non-adherence. So intentional non-adherence would be something like, I'm not taking all these tablets and you can't make me. I lived for 60 years with no medicines and now I have 10 things on my prescription and I don't want any of them. And maybe that can be addressed by having a really good consultation that gives that patient information about why we're offering these medicines. And I quite like to use pictorial representations, which I'll hopefully illustrate to you later, with the smiley faces, which show the potential benefits of drugs. I think it's really hard to motivate patients who have been prescribed 5 different medicines so that nothing happens. It's easier to prescribe paracetamol for a headache and then the patient feels better and they can see the benefit of the drug. But where we give, a mixture of beta blockers and statins and aspirin so that they don't have an event in the future, I think it must be really difficult to take those pills every day and to believe that they're doing themselves good when sometimes they feel really rubbish. So intentional non-adherence may be that they have made a decision, informed or otherwise, not to take medications. But we all know as well that there are people who are unintentionally non-adherent, which can be as simple as, I cannot pop these tablets out of the blister pack, they're too tiny, to a patient with dementia who just can't remember or doesn't understand or can't retain the information on what these tablets are here for and why they should take them. I would file those all under unintentional non-adherence. And we can make adjustments. We can put child-proof caps on bottles. We can use compliance aids, which commonly translates to blister packs, but any type of compliance aid, whether it be a medication reminder chart or telling someone to set an alarm so they remember to take their tablets, or whatever adjustment we make, whatever reasonable adjustment we make to help people take their medications, it needs to be patient-centered. So if we have someone with dementia, a blister pack may not help if they don't actually remember that they have tablets that they need to take. A blister pack may not be the best adjustment for someone who does not speak English as their first language. If they can't read the dates and the times of day on a blister pack, it's not going to be any better than giving them in original packaging. Where I work in Hackney, there's a fairly transient population. People move in and out of the area, and a big Turkish population. So we actually have a pharmacy nearby who has a Turkish pharmacist working there who can write in Turkish the administration instructions on an original pack. So that's an adjustment. It doesn't always have to be a blister pack, which are hugely time consuming and costly to put together, especially when people may not take the medications. I mentioned talking about the priorities of the patient coming in to see you. It's important to acknowledge that the patient's priorities may not align with your priorities as a healthcare professional, but we need to listen to get that engagement and say, right, what have you come in for and how would you like this to look when you leave my room today? What would feel better to you? And if, as commonly happens, they say, can you get me off all these pills? I might be able to do something with some of them. And actually, if they really, really insist on just having stuff that helps them feel better, then that's what we need to do, as long as it's an informed decision, which I know can feel quite uncomfortable, but I want people to engage in the process of taking medication, and then perhaps we can move on to, now that you're settled and stable on these, would you like to reconsider aspirin for your stroke prevention, for example? So, any questions or comments so far before I move on to a case study? Okay, so we've talked about patient-centered care, exploring how the patient is going to benefit from this consultation. I've spoken a little bit to communication. So where English is not a first language, do we have access to interpreters or advocates in the healthcare setting? Is it as simple as no one's ever been able to adequately explain what all these pills are for in a way that a patient can understand, whether that's a language barrier or whether it's a sensory impairment, for example, hearing loss or sight loss? Have we done everything we can to help a patient access their medications? Physical access, as in get the tablets out of the blister pack, or can they get to their pharmacy, or is their pharmacy maybe able to deliver to them? Or is it about understanding why we're doing this? We do capacity assessments for patients who have refused to take their medications to ensure that they have capacity to make that decision. Capacity is a decision-specific issue, and we need to explore capacity in these sorts of scenarios to make sure a patient has been able to take on and retain the information about medication, and that even if their decision is unwise, that they are making an informed decision not to take it if that's their choice. Making an unwise decision is not a lack of capacity. We want to engage people in their healthcare to make them feel a part of it. And certainly where I work, it is actually a very deprived area. And I still have a lot of older patients who were brought up to do what the doctor tells them and still call me doctor. I'm like, no, I'm a pharmacist. But they will swear up and down that they're taking all of the medicines that the doctor has told them because they want to be seen to be good patients and they want to keep the doctor happy. But when I see them in my clinic, I encourage them to be honest and to please tell me if they're not taking their medicines, because there's probably something I can do about it. Now I'm going to have a quick look at the chat because I can see a few things have come in. Oh, they're not for me, but that's fine. Right, so let's go on to...
Can I quickly ask a question before we
Oh, yes.
What's covered common administration under the ethics? I saw something like covered administration.
Thank you for asking. Okay. If a patient has capacity and decides not to take their medication, that's fine. It's not fine, but it's their decision and they're within their rights to make it. If a patient does not have capacity, and actually thank you for prompting me because I should have finished off that conversation about capacity. If a patient does not have capacity about their medication and it is in their best interests to take their medication, so for example, aspirin for secondary prevention of a stroke, covert administration is disguising administration of medication from a patient, and it is a deprivation of their liberty to do that. So this happens to me mainly in the care home environment, where a deprivation of liberty assessment has been done and granted, and we hold a best interest. So if a problem is flagged up, a resident is not taking their medication, we need to have a best interest decision meeting with the GP, the care home, probably not the patient if they don't have capacity. It can be, but usually their representative, maybe a next of kin, or maybe an independent mental capacity advocate. And a decision is made on whether administering the medication covertly in a disguised manner is in the best interest of the patient. And your minds are probably all now jumping to crushing tablets and hiding them in porridge. But we are obliged to use the least restrictive option when we are depriving someone of their liberty. And I would argue that we need to try and use covert administration in the kindest way possible. And crushed up tablets taste disgusting in the large. And some medications shouldn't be crushed. If they've got an enteric coating on so that they dissolve further down in the gut, we shouldn't be crushing them because they're going to release far too early or far too quickly. So I work with my care homes where we need to do covert administration to ensure that we aren't, let's say everyone decides to hide a tablet in porridge. I need to know that this person actually likes porridge. I also need to know that they aren't going to be so suspicious of the porridge that they stop eating. So hopefully you're getting a sense that it's quite a complex issue, and we really, really need to be careful about who we agree to do covert administration for. And there is some really excellent guidance about it, which is kind of outside of the scope of this talk today, but there are lots of resources on covert administration and capacity. And you want to have a pharmacist involved in that best interest decision meeting to do an assessment of how it's going to be appropriate and safe to administer those medicines in a disguised fashion so that it's as tolerable as possible to the patient. So an example might be Tegretol liquid, which I happen to know is orange flavored. If you mix that into their tea, which is the nearest, liquid that we can all think of that older people drink, that's going to make that tea taste pretty rubbish. But if they don't mind drinking some cordial or fruit juice, it might sit better in there. So I put quite specific instructions for carers to say, mix the Tegretol with some juice, a small amount, so we can make sure they drunk the whole dose. And then they know how it's going to be tolerated by that patient. Some tablets may not be available in a liquid formulation, but they might be so small that you can slip it into a mouthful of porridge without them really noticing. Other tablets are chunkier, like a metformin tablet, where you have to be a bit more imaginative and probably use a liquid. Does that answer your question?
Yes, please. Thank you very much.
Oh, you're
Sorry,
very
I have
welcome.
another question, please. Is it advisable to use patient's relative in the case of language barrier to interpret to the patient?
With the consent of the patient, it's okay. It depends what the consultation is about, doesn't it? You'll know we sometimes have parents bring their children in to interpret for them, which is very rarely going to be appropriate. But if an adult brings in another adult, and we're not talking about something that's terribly sensitive, and the patient appears to be consenting, then yes. If that doesn't seem appropriate, then well, as far as I know, all practices and healthcare settings will have access to a telephone interpreting service or have an advocate floating around, or some way of working with a patient to help them understand. And that could be calling a relative to help translate.
Thank you very
Okay.
much. Thank you.
Thank you. Right, so we want to make sure that if we have to offer a number of medications to a patient, that all of those medications are appropriate. Are we using the right medicine for the right person at the right time? And those things can change over time.